All right, good morning, everybody. My understanding is that each of us have 45 minutes to cover all of viral hepatitis, syphilis, and every pertinent STD. So hang on, it'll be fun. You guys have a lot of experience, I think, all the way from medical school through residency into fellowship about viral hepatitis. What I'm going to try to focus on here are some of the nuances or things that you may be specifically asked as a ID consultant about the management. So sometimes that's going to be management of an outbreak. It's going to be who do you treat and how, especially in special populations like immunocompromised individuals, et cetera. There's more information here than that, and we'll move through that more quickly. So we're going to try to understand virology, epidemiology, clinical presentation, clinical management, long-term follow-up of hepatitis A, hepatitis B, and hepatitis C. The main information for you to know regarding treatment of the two chronic hepatitis, hepatitis B and hepatitis C, is that we make our treatment decisions based on consensus guidelines. And the best resource to decide which therapy is most appropriate for the individual patient that you're dealing with are those consensus guidelines. They change periodically, and they're always an available reference. It is unlikely on your ID boards for things like hepatitis C that you'll be asked, this person has this genotype, choose this specific antiviral agent to treat them. You may be asked, is this patient a candidate for treatment? Or what things might you be concerned about when treating someone? And for hepatitis B, you're unlikely to be given a scenario where someone has clear chronic hepatitis B and they say, are there medications we can give to treat them? You may be given situations where an individual has potential chronic hepatitis B that is inactive and has a risk for that reactivating because of some immunocompromised state. So think of those as we move forward. Hepatitis A is our first one. It's called hepatitis A. If you forget, there's a giant A there. What do you guys know about hepatitis A? It's an RNA virus. As an RNA virus, it doesn't integrate into our host cell genome. Good news. Epidemiology of hepatitis A is one you're familiar with. This is fecal oral transmission, and there are certain high-risk groups that are more at risk to getting it. People with close person-to-person contact, sexual contact with an infected person, ingestion of contaminated food and water, and fecal oral transmission can also occur with drug use, shared saliva through needle exchange, etc. So don't keep that out of your range of potential transmissions for hepatitis A. Hepatitis A is an acute infection when it presents clinically, and it is a self-limited infection that resolves on its own. Treatment that we provide for hepatitis A is supportive care. Treatment we provide for hepatitis A is preventing people from getting hepatitis A through vaccination or immunoglobulin treatment. And management we provide for hepatitis A is advice on how to manage a source-based outbreak. Those are the things that you want to be aware of. Incubation period of a hepatitis A is about anywhere from 15 to 50 days, average of about 4 months from when someone is exposed. We have recently experienced relatively remarkable outbreaks of hepatitis A in the US. If you look at our cases on a year-by-year basis, back in 2019, those cases rose dramatically. These cases seem to be more related to clusters of MSM transmission, clusters of drug sharing transmission. Most of these aren't common food-based source control outbreaks. In 2020, those rates went down. That correlated with the timing of the COVID pandemic. We will see as we analyze data in the future whether these rates go back up again with behavioral change. But these are the things we're seeing. Ways to control these numbers: vaccinating people who are at risk for acquiring hepatitis A. This is CDC data about all the different places where people have hepatitis A as acute index cases. The US average is about 3 cases per 100,000 population. Way up there in about 10th or 12th on the line, you see Florida. We have been above the national average of cases in both of those times, with all of those darker green bars representing the bigger outbreaks of 2019. Who can get Hep A? International travelers can get Hep A. When you're counseling someone about travel to an endemic area, hepatitis A vaccination, if they haven't been already, should be part of that conversation. MSM, IV or non-IV drug use. So we could just cross that out and say drug use. People with an occupational risk exposure. People who may have close contact with an international adoptee, someone who's bringing a child from a different country. Homelessness is a risk. And people among all those risk groups who are more likely to have a severe infection that may require hospitalization include people who already have underlying chronic liver disease or people with HIV. So why do we vaccinate our HIV patients against Hep A? Because they are people living with HIV. If they are co-infected with another hepatitis, their risk of Hep A being worse is profound. So if you know someone with Hep C, vaccinate them for Hep A. See someone with Hep B, vaccinate them for Hep A. If they have HIV, vaccinate them for Hep A. We rarely see acute cases of hepatitis A, and sometimes we won't even be called for them because the treatment is largely supportive care. But the CDC does have case definitions of what defines an acute case of Hep A, and this is not simply that you found serologic evidence of Hep A, it is that the patient has symptomatic disease. That can be any of a number of clinical findings. They can include obvious jaundice, nausea, vomiting, etc. But within the symptomatic complex could be things as simple as fever and headache. So viral syndrome is enough as a minimum. You have to have laboratory evidence, which includes jaundice and markedly elevated transaminase levels and the absence of a more likely diagnosis. So they could be serologically positive, but if something else is causing those, it might not be a true case. You also need to find evidence of either Hep A IgM or evidence of Hep A RNA by a nucleic acid amplification test. All of those meet the acute definition. Interestingly, kids very unlikely to manifest clinically with acute hepatitis A after exposure, more likely to have an immune reaction that clears the virus on its own. Adults more likely to get symptomatic disease. And of adults who get symptomatic disease, most will become jaundiced. That's great news what happens for kids when we talk about Hep A. They don't get sick. It's bad news for kids when we talk about Hep B because they also don't get sick, but they also don't clear their virus. So those are important things about time of acquisition. Kids getting Hep A, great news. They're probably going to be okay. Kids getting Hep B through vertical transmission or early at the time of delivery, higher risk for chronic Hep B from the point of infection. And adults who get Hep B, much less likely to have chronic disease. How do we manage clinically? We do supportive care, whatever that means. Here's some pain medicine, here's some fluids. Hope your stomach feels better and be on your way. The most important thing for us is prevention, a 2-dose Hep A vaccine series. It can be given singly. It's also available as a Twinrix vaccine combined with Hep B. Either of those are reasonable options. In a high-risk outbreak, in addition to vaccination, we can give people immune globulin therapy if they are immune naive. This is especially important for unvaccinated individuals. This is not a Hep A specific immune globulin formulation. It's a combined immune globulin formulation, and its efficacy seems to be decreasing over time because there's not as much Hep A immune presence in our combined vaccine, our combined immunoglobulin population. So vaccine is still our better strategy. You may sometimes give immunoglobulin therapy to a traveler who hasn't been vaccinated and is going to an endemic area before they have immune effect. That's the other place you'll see that given. Who should get vaccinated? Nearly everyone should get vaccinated. I'm not going to read all of these. You see all of these risk factors. An important one on the right side is anyone who wants to get vaccinated. So if you have risk for Hep A, get vaccinated. If someone says, can I get a Hep A vaccine? Get vaccinated. If you say, do you want a Hep A vaccine? And they say, yeah, then they said yes, and you can vaccinate them as well. So occupational risk is one that's there, and it is a more and more limited group. It used to be thought that people that worked in sanitation or sewage work were an occupational risk group because fecal oral transmission was circulating around them. Some people will still choose that as an occupational risk category, but the likelihood of acquiring Hep A in that work is pretty low. So that's one where more of those folks are probably just going to be in the someone who requests vaccination as opposed to a true occupational risk. Hep A, are you happy with Hep A? We vaccinate for it. I do want to talk a little bit about outbreaks of Hep A. You will hear in the news periodically of a restaurant source of Hep A or an institutional source of Hep A. And what do we do in those settings? In general, for a restaurant establishment that people come and go from, we don't contact trace and try to find individuals at risk because those were limited individual contacts. Unless there is a clear source worker that we know didn't wash their hands, practiced unsanitary practices, and had contact with raw food. If all of that is known and the case, you can try to contact patrons. But patron contact in a restaurant is a pretty hard thing to do. That's a different situation than if you have a Hep A outbreak in the school cafeteria or the prison or a congregate living situation where that same common source worker is preparing food for people every day and the amplitude of contact goes up. In those cases, you're going to give prophylactic vaccine or immune globulin to those patients who are at risk. The patients at risk are those who haven't been vaccinated yet. And so you want to have that information as well. So if you're managing a congregate living situation, if you collect data on immune status of your patients or residents coming in, it can help you if any of those things occur. And in most of these cases, the local health department is going to be helping to manage that contact as well. But that's the big thing for Hep A, how to manage those outbreaks. Hepatitis B, have you heard of it? It's the second one. Hepatitis B is nasty because it decided to be a virus that can integrate into our host cell genome. Viruses that do that tend to stick around with us, and hepatitis B is one of those. Virologically, it's a double-stranded DNA virus, and it can exist in two forms. Its most likely replicative form is a covalently closed circular DNA that lives outside of the host cell genome. That is potentially clearable with treatment or immune activity. It can also integrate into the host cell genome, and that doesn't go away with immune activation or treatment in most cases. So that's the challenge we face with hepatitis B. The US isn't a high prevalence area for Hep B. Hep B is a much more significant global health problem. There are about 300 million people worldwide chronically infected, probably 1 billion who have at some time had an infection, the majority of which have cleared it serologically. Here's our cases of Hep B in the US. It remains a high incident and prevalent problem. Again, behavior changes in that 2019 to 2020 area might have led to a slight decrease. Florida, a higher prevalence area. So if you're practicing here or anywhere close by us, we're a higher prevalence area of Hep B for certain behavioral reasons. Hep B, as you know, is a bloodborne transmission. Factors for acquisition are very similar to those that you would see for HIV infection. When we look at this in the US by race and ethnicity, the preponderance of prevalence per 100,000 population is in Asian Pacific Islanders, where there is a much higher endemic rate of hepatitis B. If you see someone who is an Asian Pacific Islander, screening for Hep B is probably a good idea, especially if they are not born in the US, but were born or raised there, because the likelihood of acquisition is much higher. Hep B and consequent hepatocellular carcinoma is the leading cause of cancer-related deaths in Asian and Pacific Islander countries, because children acquire the infection vertically, and from the point of age 0 to just age 25 or 30, they have chronic inflammatory hepatitis. And so this is an early cancer that occurs with a long-term infection. We can define acute and chronic Hep B in the same ways we do with Hep A. We can't define chronic Hep A, but acute Hep B is an acute illness with some of those same viral signs. Patients will be jaundiced, and they'll see ALT elevations. The case definition for ALT elevation is a little lower for Hep B than for Hep A. If you see that patient and they are Hep B surface antigen positive or have IgM, early antibody to hepatitis B core, that is a confirmed acute hepatitis B case. That's the CDC case definition. Most of us will also do hepatitis B viral DNA at the same time, and that gives us a lot more comfort that we detected acute viral replication as opposed to simply relying on serology. There is one extrahepatic manifestation of acute Hep B that you may see, which is a serum-like illness. And so in the absence of those other symptoms, that may also be the initial manifestation. For chronic infection, it's someone who doesn't have any of this, but has laboratory evidence of Hep B. That means they are IgM to core negative. They've cleared the acute serologic evidence, and they can be positive for a bunch of other things. Any of these define a chronic infection. Absence of IgM core plus surface antigen, envelope antigen, or Hep B viral DNA. Now, as you all remember from your microbiology classes, there's a bunch of serologic patterns with Hep B. It can be in the window. They can have cleared one thing or the other, or the other, or the other, and it drives you crazy. The important thing in diagnosing someone with chronic Hep B is because of these shifting serologies, if you only have a pinpoint single time of checking those surface antigens, E antigens, or DNA, you want to have evidence of those same things also being positive at least 6 months later to confirm a chronic infection. In the absence of that confirmation, a patient could have that pattern and still be in an acute clearance phase of their hepatitis B. Why is it important for us to identify and treat hepatitis B? Because despite the fact that you guys may be bored by viral hepatitis, it is going to be the leading cause of death worldwide. People are going to die from cirrhosis, and they're going to die from hepatocellular carcinoma. We're not seeing that here in large numbers because we don't have a high Hep B prevalence. We see death from those things from Hep C. But in the rest of the world, those 300 million people chronically infected with Hep B generally aren't accessing effective treatment and have that high risk of death. So big cause of morbidity and mortality will exceed TB, HIV, and malaria. I don't know if there's any Gates Foundation funding, but be nice. How do we diagnose Hep B? Man, it's a challenge. So these are the different serologic patterns that people can see. On the right, you see the definition of what those patterns mean. I've put stars next to things that represent good news, bad news, and equivocal news. Good news is you were vaccinated against hepatitis B and you never had hepatitis B. That's good news. That means you should be able to not get infected with hepatitis B because you are immune protected. Bad news is chronic infection. You have detectable surface antigen. You have detectable core. You have detectable Hep B DNA, and you've confirmed that in subsequent testing. Everything else you see there could be bad news. If you're in an acute infection phase or an acute resolving phase, we don't know what your status will be until we see that later. And the one that is particularly frustrating is the second from the bottom yellow star. You can be core positive. You can be Hep B DNA positive or negative, and you don't have any evidence of viral replication. But is the virus in your system? Possibly. Can it reactivate? Possibly, especially if we take away the immune surveillance that's keeping it from replicating. Now, do you want even more bad news? I could put a positive/negative in the anti-Hep B surface column, and the same is still true. A patient who made surface antibody to a real hepatitis B infection can reactivate that infection when they are given potent immunosuppression. One of the ones we think the most about that you guys might see here at Moffitt is when we give someone rituximab and we have to prevent a reactivation. When they do retrospective studies of people who had reactivation of Hep B when given rituximab, you were just as likely to reactivate if you were surface antibody positive as if you were surface antibody negative if you had a chronic infection, with about a 4% reactivation rate in both of those arms. So can you tell someone who's been infected with Hep B and has a surface antibody that they're clear and they'll never get the infection again? No. What a pain. The virus is not as kind as it should be. Who do we treat for Hep B? Treat people with decompensated cirrhosis. We can give them antiviral therapy and refer them for liver transplant. Patients with cirrhosis, if they have a Hep B viral DNA anything above 2,000, great candidate for treatment. And these are all from the AASLD 2018 Hep B treatment guidelines. Those are pretty easy treatment choices. People who had bad liver disease and Hep B, we treat. The most confusing category is this one that we call immune active hepatitis B. There's a bunch of lab criteria and other things that we use to decide who to treat. Immune active disease means the body has begun to respond to the Hep B and is responding in a way that is probably promoting ongoing hepatocellular damage. And we'll look at a slide about how those patterns work. Immune active disease is defined first by evidence of viral inflammation in the liver, increased ALT of at least 2 times the upper limit of normal, elevated Hep B DNA. And here, the amplitude of that DNA elevation is based on whether the patient has mounted a Hep B envelope antigen response or not. When they have not done that, the virus tends to replicate at a lower level but still cause inflammation. When they have switched to Hep B antigen positivity, they replicate at a higher level and cause ongoing damage. If you're looking for the ALT levels that trigger 2 times the upper limit of normal, it's recommended in the guidelines to use a level of 35 for males and 25 for females. So you're going to see 50 as a threshold of reasonable treatment for a female. Here's what we talk about when we're talking about immune tolerant disease. If we look at a patient who is Hep B antigen positive, the virus is replicating, the antigen is there, the body hasn't yet made antibodies that clear that out. They have high viremia. They don't have a lot of ALT. The body yet hasn't really had a lot of immune reactivation or immune damage focused on the liver. As the virus continues to replicate, ALT levels increase. What often happens in that case is that we may begin to clear the virus. So Hep B DNA levels might go down as the ALT levels are going up, but they don't clear completely. So in a Hep B envelope antigen positive case, viral loads tend to be higher in active disease. When you move to a hepatitis B envelope antigen negative case, Hep B viral DNA levels tend to be lower, but still could indicate ongoing viral replication. So those are the reasons we have those 2 different thresholds. When you are dealing with a case of that, you're going to go to the guidelines and say, I have my 6-month separated tests. I have a patient with ALT elevation. I'm going to look at their Hep B DNA levels and make a decision about treatment. Okay? Do I expect that you'll remember all of these thresholds or not? No. What you do want to remember is, hey, I have someone with chronic Hep B. I think I need to look at the amplitude of their Hep B DNA to make a decision about treatment. So who do we treat? In addition to everyone we talked about, we also treat people that are over 40 that have a normal ALT level, but markedly elevated Hep B DNA. So even outside of that immune tolerant level, if you have someone who has ongoing chronic Hep B and a profound Hep B viral load, we treat them as well. Other people we treat. Pregnant women. Why do we treat them? To prevent vertical transmission. People with HIV and hepatitis B, why do we treat them? Yes, for exact murmur reasons that you said. That we treat them because they're at risk for more severe liver disease because of their underlying HIV. And it's super easy to treat them for hepatitis B because all we really have to do mostly is treat their HIV, and magically their Hep B is being treated in the majority of cases, as long as you don't alter their antiretroviral therapy to not include agents that work against Hep B. What antiretrovirals work against hepatitis B? Tenofovir. Do both tenofovirs work against it? TDF and TAF? Yes. What else? Entecavir. And how often do you treat your HIV patients with entecavir? No. It's not an antiretroviral, but it's a great Hep B drug. Lamivudine. And what else? And M-tricytidine. So in your HIV treatments, is your nucleoside-nucleotide backbone typically composed of tenofovir and M-tricytidine? If it doesn't include those, does it often include lamivudine? Sure. So in most cases, we're treating. However, you have a chronically infected patient and you alter their therapy and say, I need to change because of resistance, and you inadvertently take away their Hep B active agents, you may see a flare of their Hep B. You may be confused to say, oh, now they have LFT abnormalities because they have a medication toxicity to whatever I changed, when really you just allowed the Hep B you were treating to flare up. We also treat people who are going to get PrEP. Does PrEP have activity against hepatitis B? Yeah, so are we treating those people anyhow? Sure. But do PrEP patients maybe have the possibility of saying, I got tired of taking my PrEP, so I'm going to stop, or I'll take it intermittently? So we need to look for Hep B in those patients so we can say, hey, it is more important for you to continue to take this because you may develop resistance to Hep B antivirals if you're taking these intermittently. And then we have this annoying group of patients. The patients are nice. Their clinical conditions are annoying. Persons at risk for Hep B reactivation. People taking immunosuppressive therapy, cytotoxic therapy, disease-modifying antirheumatic drugs. The big things that we worry about, things like rituximab, anthracycline-containing chemo, TNF-alpha inhibitors, and even prolonged corticosteroids for more than a month. Any of those folks with evidence of chronic Hep B are at risk for reactivation. And that evidence of chronic Hep B can include only core antibody positivity. And those are the patients that we tend to treat. Risk of reactivation is higher if they also are surface antigen positive. Risk of reactivation isn't really changed if they're surface antibody positive or negative. So we, in the past, maybe 20 years ago, said, hey, a core positive without antigen positivity, you probably have enough immune activation to prevent reactivation. And then we gave people much more powerful immunosuppressing agents and said, oh, well, we're wrong. That didn't work. We need to do something else. How do we treat Hep B? Lots of different options. The ones that we use now are mostly entecavir and the two different forms of tenofovir. Do we ever use interferon anymore to treat hepatitis B? What's that?
It's fallen out.
It has fallen out of favor. Why? It's the first one. It's got a great history. Interferon is a highly toxic super side effect drug. It does have one advantage over oral agents in the treatment of hepatitis B, in that it is the only drug for hepatitis B that could potentially clear the infection. So people can seroconvert and not have viral replication after a successful course of interferon. And when we treat people with interferon for hepatitis B, we do it almost in the same way we do for hepatitis C. Around a 48 to 52-week treatment course, checking for mid-treatment and end-of-treatment virologic response. And then we prove success or failure with a sustained virologic response 12 to 24 weeks later. About 50% of people may have that success or lower. Most people don't want to take this. The reason we have other options is entecavir, tenofovir in both formulations are now highly effective, low side effect drugs that people can take. And as long as they continue to take them largely indefinitely, we can control their hepatitis B. Here's the current sort of approved antivirals for hepatitis B. Do we use adefovir very much anymore? We don't, because its activity can largely be achieved with tenofovir, and tenofovir has a higher barrier to resistance, and especially we felt risky using adefovir in HIV patients because it has theoretically some marginal antiretroviral activity, but not enough to treat HIV. Entecavir, a nucleoside analog, highly potent, high barrier to resistance. The one that can still be used, but mostly we're just using it as co-treatment for HIV patients, is lamivudine. That used to be the mainstay of Hep B antiviral therapy. It has a low barrier to resistance, and people typically broke through with resistance after 1 to 2 years of therapy and needed switched. That doesn't happen really with the newer agents. These are the breakthroughs for resistance if we compare lamivudine to adefovir to all our current recommended agents. So people have multi-year successful virologic suppression without resistance breakthrough on entecavir, tenofovir in both formulations. There used to be debates of whether we would give dual therapy or monotherapy for Hep B. For a non-complicated Hep B infection without HIV co-infection, monotherapy with one of these agents is appropriate and successful. If you do use pegylated interferon, again, we're trying to clear the infection. That would be a patient choice. In general, most patients don't elect that. All of the others that we mentioned there are effective, once daily dosing, indefinite treatment. The only times that that treatment might not be indefinite is if you've chosen to give it to someone who you're preventing reactivation because you're going to immunosuppress them. In those cases, it is probably okay to stop the Hep B treatment 6 months after you've completely finished any immune modulating drugs. So for people with rheumatic diseases, that might be never if they're on that lifelong. If someone's getting chemo, there could be a point where you're done with that and able to stop that therapy again. How do we prevent Hep B? We vaccinate. And here's the differences in CDC recommendations for vaccines. We used to vaccinate risk groups, then infants born to infected mothers, then all babies, then everyone up to 18. And then we started giving it at birth. And then we said adults less than 59 with diabetes. And now we say all adults. So it's nice when the CDC makes things easy for us. Now, if you're an adult, you can get vaccinated for Hep B if you want. We don't need to identify a certain fancy risk group. And you can also ask them, hey, do you want Hep A vaccine? And if they say yes to your gentle cajoling, give it to them as well. We are often facing vaccination for our immunocompromised patients, for our HIV patients. And there's a lot of different debates we have about, hey, what do we do because someone didn't get an immune response? This is what you do in someone who didn't get an immune response to their Hep B vaccine. After their first series, you check their anti-Hep B surface titer. If it's less than 10, give them another complete series. Check again 1 to 2 months after. If they didn't seroconvert again, they could have hepatitis B, so make sure that they don't have an active infection. If they're seropositive, meaning they've converted, they're immune. Otherwise, you look for it. If their Hep B surface antigen and is negative and their Hep B surface antibody is not high enough, we don't revaccinate them, but we need to know that those patients are at risk for acquiring hepatitis B. They're non-immune. Usually we try to give these patients double dose Hep B, twice the standard dose. And some people will even recommend for non-responders, rather than revaccinating with a 3-dose series, to vaccinate with a 4-dose series. So we usually do 0 month, 1 month, 6 month. A 4-dose series would be 0 month, 1 month, 2 month, 6 month. And that's probably a reasonable approach for non-responders, because once you've done that second series, that's as much as you're throwing out. That's for HIV infected individuals. An interesting thing we were just talking about in VA clinic was checking serologies to see if we needed to revaccinate someone who has already been vaccinated. We don't do that for HIV patients who have successfully responded, but that is done in the dialysis population. So for a dialysis patient, everything else we talked about is true. If they failed once, revaccinate them at high dose. However, if they mount an immune response and show successful response to the vaccine, dialysis centers will check their anti-Hep B surface antibody annually, because it is thought that dialysis weakens the immune system to a degree that they may need revaccinated again if it falls. And they don't do a whole series, they do a booster at that point. No one's really studied that in the HIV population. May be an interesting thing for someone to look at. C, the third and final hepatitis. RNA virus, it's in the Hepativirus genus, which is just kind of trying to make hepatitis C sound Latin. It's related to some cool other things like yellow fever, West Nile, and dengue virus. We know the risk groups. Blood is the main route of transmission for hepatitis C. IV drug use, any non-injection drug use, snorting cocaine, other things where there might be some mixing of blood. Sexual exposure is a risk, but a low risk. If you look at serodiscordant couples where one is Hep C positive and the other is Hep C negative, there's less than a 1% risk of Hep C acquisition on a year-to-year basis. So this isn't completely analogous to things like Hep B and HIV. It is different in its transmission, and really blood-related transmission is that high risk. Tattoos and piercings is a risk if you're not getting your tattoo and piercing at a licensed place. People can probably safely go to most licensed tattoo parlors or piercing pagodas, and they'll be fine. There is a decreasing population of people who have Hep C or are at risk for not yet being diagnosed with it because of receipt of blood products in the 90s before things were universally tested. Most all of those patients who may have acquired it at that point, we've already recognized. Here's our new Hep C infections over time. As you see, giant diagnostic volume in the mid-80s and into the 90s because of all of the lack of recognition of transmission in blood products, and also because that's when we got tools to diagnose hepatitis C. So there were tons of people who had it probably before 1980, and we called it non-A, non-B hepatitis. Then we got diagnostic testing, and when you finally can look for something properly, then you can find it. There was a bunch of it. Rates have gone down. The birth cohort of the baby boom was a high-risk group for that surge you see right there. Here's what can happen with Hep C, depending on the color of your avatar. If you get a new Hep C infection, you are eligible to enter into the mother computer from Tron. I don't know if any of you saw that. It's a spinning thing with a face and talks from the 80s. So anyhow, you can enter that, and that is a new person with a Hep C infection. Some people get to not go in because they turn green, because about 20% of patients with an acute Hep C infection can clear it spontaneously. And the good news for Hep C, if you cleared it spontaneously, you don't have hepatitis C anymore, unless you get it again from some other source. Of the people who go into the mother computer, some will die. Do we know who will die from Hep C? No. There's no predictors we have that are very reliable to say this person with Hep C is likely to carry it chronically without complication, and this person is likely to progress to cirrhosis or hepatocellular cancer. Everyone in the center is potentially at risk for that. As we treat people, successful treatment for Hep C is a cure, and they only are going to be Hep C positive again if they get reinfected. Before the age of direct-acting antivirals, hardly anyone got to become a green person on the other side. Even our most successful treatments were only about 40 or 50% successful. Now, our highly effective oral direct-acting antivirals are 90 to 95% successful in curing hepatitis C, and they do it with minimal side effects. The new medications for hepatitis C were amazing breakthroughs that transformed the treatment of this disease. When you're screening for Hep C, there's all those other risk groups we talked about. Another risk group is just being born between 1945 and 1965. The seroprevalence is high enough that regardless of identified risk factor, we recommend screening for Hep C in that birth cohort. Acute Hep C can happen. It is someone who you find with an acute hepatitis picture, and they have detectable Hep C viral load or antibodies. More likely than not, we're always dealing with chronic hepatitis C. They have an anti-Hep C antibody and evidence of viral replication. And typically that evidence comes from a Hep C viral load. It is important to note that in the rarest of occasions, people can have transient, undetectable viremia with chronic Hep C. So to prove that someone has fully spontaneously cleared Hep C, if they haven't yet been treated, you should check a viral load twice, separated by 6 months. If both of those are negative, you can say you are one of those lucky people that never entered chronic Hep C at all. If at any of those times you detect Hep C positivity on RNA, the next things you do are determine the genotype of that infection to determine the best treatment. In addition to clearly active Hep C with the complications we talked about, and the complications of hepatocellular carcinoma and cirrhosis, remember that Hep C can also cause some extrahepatic manifestations. These are things you may or may not see on your board exams. Cryoglobulonemic vasculitis is a common extrahepatic manifestation of Hep C. Chronic kidney disease with immune complex deposition. Patients with Hep C are more likely to transition to type 2 diabetes, and there's even a higher risk of B-cell lymphoma. All of those are reasons we want to treat everyone that we diagnose. So who should we treat? Well, now Hep C is easy to make that decision. The answer is everyone who you don't think is going to die soon. So if someone's going to die of something else within 12 months, then there's no reason to treat their Hep C to prevent cirrhosis or hepatocellular carcinoma. Anyone else should be treated. A thing that I will say in clinic, if someone asks, should this patient be treated? I ask on physical exam, on HENT, did they have a mouth? And if the answer to that probing question is yes, I recommend treatment with oral antiviral therapy. We can treat decompensated cirrhosis. We can treat patients with renal failure. We can treat patients with ongoing substance abuse for their hepatitis C. Prospective studies of successive treatment have shown that all of those categories of patients successfully can be treated. There were times we were wary to treat people with ongoing substance abuse because are we going to breed resistance or are they going to get reinfected? No, remember that their behavior is a thing that's putting them at risk. They should be counseled for use of clean needles and other things. But to tell a patient who has a potentially life-altering disease that could kill them, I'm going to wait to treat you until you clean up your act, even though I have remarkably successful medications, is kind of ridiculous. So treat people with Hep C. Could they get reinfected? Yes. And then you readdress that situation. There's a few contraindications to therapy. If you are doing interferon-based therapy, avoid it in pregnant women, women who can become pregnant, and men who are sex with women who can become pregnant. Ribavirin therapy is largely a part of interferon-based treatment, which we hardly ever use anymore. There are some relative contraindications to treating people for Hep C, and they are mostly if things like substance abuse or psychiatric disorders will significantly impair their ability to even come to follow-up appointments or be monitored on treatment. So if that's a reason to avoid treatment, that's reasonable. If it's just that someone's using drugs but is eager to come to their appointment, that's not a reasonable reason to defer treatment. So how do we treat Hep C? We use the Hepatitis C treatment guidelines. These are protocol-driven and they're updated as new data becomes available. There are 3 classes of direct-acting antivirals that work on specific mechanisms for the Hep C virus. The first and oldest of the direct-acting antivirals are Hep C protease inhibitors. They prevent cleavage of the Hep C polyprotein. Next developed were the NS5B polymerase inhibitors. These help to mediate Hep B replication. And finally, the third class are inhibitors of an enzyme called NS5A. And this is the definition from the guidelines. It's a viral phosphoprotein that plays an important role in a lot of things the Hep C virus does. Great. Works effectively. In nearly all cases, we are now using these drugs as combination therapy with two drugs combined together. What do you need to do to decide how to treat someone? You want to look at their genotype of hepatitis. How many genotypes of hepatitis C are there? 6. Are there any genotypes of hepatitis C that can't be successfully treated with direct-acting antivirals? No. But you do need to know the genotype so you can choose the right therapy. There are pangenomic therapies that are effective against all genotypes, and there are some that are only effective against a few. These are all of the different classes of medicines. I'm not even going to read them to you. You'll find them on the guidelines. But some are genotype specific. I will point out Zepatier is one that we need to do NS5A resistance testing before treatment because there's a higher likelihood of failure there. Maviret, one we frequently use, pangenomic, effective without any resistance testing. Harvoni, effective against multiple genotypes and can be used in decompensated cirrhosis. And the same is true of Epclusa. Why can those be used in decompensated cirrhosis? Because they are agents that don't contain a protease inhibitor. And the Hep C protease inhibitors are more likely to exacerbate decompensated cirrhosis. So if you have someone with decompensated cirrhosis, use a PI sparing agent. And then the final one you see, Vosevi on the bottom, pangenomic, probably reserve that for people who have had treatment failure on a prior regimen. It contains each of the classes together. Okay? Does that make sense to you? When you go to the guidelines, there may be specific minimal side effects that are different from one drug to the next. But I will tell you that side effects for the Hep C drugs are remarkably minimal, and the drugs are remarkably effective. So choose wisely, do proper resistance testing if necessary, avoid PIs and decompensated cirrhosis, and choose a therapy based on the patient's genotype. How do you? So that is, it is hard, but not impossible. It is easy to determine if the new virus is of a different genotype. If it is of the same genotype, and again, in the US, the most common genotype is genotype 1. So even someone reinfected again is still likely to have that. You're probably going to treat them as a reactivation or treatment failure if you were not able to prove a successful sustained virologic response. And so that's the last thing we'll talk about here. How do we know that we've been successful on treatment? We look at viral load clearance. So it used to be we would monitor this on therapy every 4 weeks or so. Is it working? Is it working? Is it working? The current guidelines for monitoring people with Hep C treatment are modified because our treatment courses are so short anyhow. In some cases, we're giving people drugs for 2 months. So to determine whether you've been successful, you're going to have a patient who has a baseline detectable viral load. You're going to treat them. And then 12 weeks after treatment, you're going to check their viral load again. And if it is undetectable, the treatment worked. If it is not, they may have gotten reinfected. They may have had a treatment failure. For those particular patients who you think might have ongoing risk, you may want to get an end of treatment viral load as well to say, hey, at least I knew you were suppressed at that point. But the only way we know that a cure has occurred is that sustained virologic response at the end. We know that treatment didn't work if the virus was detectable at the end of treatment. So no one has detectable virus at the 8-week point and then later clears. But in most cases, that doesn't lead us to alter therapy anyhow. So there's no point in checking until you're just done. Any questions? Yeah. Yeah, so when we've treated Hep C in the past, there have been reported cases of patients having a flare of hepatitis B. So it is recommended that if you have someone with evidence of chronic Hep B that you haven't treated, that you treat them during Hep C treatment. That means they could be in that category similar to someone you're giving rituximab to. I'm going to treat their Hep B while I'm treating their Hep C, but it's a very time limited thing. And then that 6 months of treatment is done pretty soon. Okay. And all of these are pretty tolerable. All right. Yes.
Infection and durations.
For reinfection, the treatment is sometimes a little longer. So those might be with the triple therapy could be anywhere from 12 to 16 weeks.
For the women in childbearing age, is it recommended that they want some type of like contraception?
If they're taking ribavirin, it would be recommended that they go on contraception. And we did that with 2 different methods when the only treatments we had available were interferon-based therapy. At present, it would nearly 100% of cases be don't use an interferon ribavirin-based therapy for a pregnant woman. But we have ribavirin therapy that we theoretically propose for other viruses at different times. Ribavirin is a general antiviral. It's a kind of non-specific in its activity. So it's proposed for use sometimes often in emerging viral pathogens. Just remember ribavirin is a teratogenic agent. And so it should really be avoided in pregnancy. Interferon, if you've never used it and just want to know about the side effects, I'll tell you about it. It makes people feel like they have severe influenza for 12 months. It leads to profound cytopenias. People get thrombocytopenic, anemic, etc. And it requires frequent monitoring of that. So you're giving someone a medication that makes them feel bad and that they have to come in for frequent monitoring for. It doesn't work well for Hep C without the addition of ribavirin, which itself amplifies the hematologic toxicities of interferon. So hard treatment courses. People who successfully made it through only had about a 50% chance of cure. And if you did sort of an intention to treat of people who actually made it through a treatment course, you're more in the 30% or less success range because so many people drop off of therapy. With the new direct-acting antivirals, people finish their treatment. You can often convince someone to take a pill for 8 weeks, and then once they've forgotten to take it each day, they're done with their treatment course already. I have treated people in free clinics with direct-acting antivirals. They do fine with very minimal outpatient monitoring. They get the meds, they take them, they come back a few months later, and we check for a cure. So they're great medications. They're one of probably the biggest infection breakthroughs we've had in the last 25 years.